Hi there, it's me. Sorry, forgot I was on. Today we are going to be studying the wonderful neurological system. Now, as usual, this is my favourite. Well, actually, it's not my favourite, but it is one of the most interesting things that we can study in medicine. Again, as usual, today we're only really going to be touching the surface because there's so much to learn about. What we'll be going through today is the usual assessment. We'll be looking at history, red flags, observations, and then we'll go into some further history. So we'll ask specifically about headaches. We'll be looking at meningitis. We'll be looking at the mini mental test, the cranial nerve tests, and the cerebellum function tests. There's loads to do here and there's loads to do in your homework, so do as much as you can, and when you finish this module, please keep adding to your knowledge. This is unlimited. All right, so before we start, we've got a little activity. Let me just, make sure this moves on. There we go. All right, so before we start, I want you to take a few minutes, pause this video, and answer the following questions, or look them up if you can't answer them. So, what is the peripheral nervous system and what's the central nervous system? This is going to take you way back to Nanny Pat's course again. I feel like I'm saying that every single time. But fundamentally, A and P, first of all. Once you remind yourself about what the central nervous system and the peripheral nervous system are, then I want you to look at the brain itself. So when you learnt the anatomy of the brain, I'm sure you could tell which bit was which. However, did you actually learn the functions? So take time now to learn the functions, revise this of the cerebellum, the cerebrum, the cerebellum, the midbrain, the pons varoli, the medulla oblongata, the hypothalamus and thalamus, and the spinal cord. All right, that'll probably take you about 15 minutes. I also want you to have a little Google about the pituitary gland. Whereabouts is it and why is it important? All right, pause the video, grab yourself a cup of tea, and I'll see you in about 15 minutes, I think. Unless, of course, you've just forwarded on. All right, so this is what we're doing today. So I'm trying to give you a greater understanding of the assessment and management of neurological disorders. To do that, we're going to make sure that you can have an increased awareness of the pathophysiology of the nervous system, looking at common neurological conditions and disorders, excuse me, and looking at how we assess them as a paramedic. So as I said earlier on, this is the way in which we'll be carrying through this lesson. At any stage, just pause. All right. I have put up a static version of this too. So I've done my best to make sure I wasn't blocking out anything apart from the University of Greenwich logo. But there is a static version should you just want to have a look at the PowerPoint. This does not include all of the information you need to do. You need to have completed all of the lessons in order to say that you're finished in the neurological system on this module. All right, so first of all, activity again. So another 10 minutes. Can you write down the neurological red flags? There are so many of those. So we're thinking about things that are specifically dangerous within the neurological system. So if you said vomiting was a red flag, for example, I'd be saying, well, why is that a red flag in the neurological system? You would need to say, okay, trauma plus vomiting, head injury plus vomiting, seizure plus vomiting, headache plus vomiting. You know, on its own, vomiting is not a red flag in the neurological system. Seizures, on the other hand, fainting, loss of consciousness, all those are. So here I go, giving the answer away. So pause me and see what you can come up with. I've put a little hinter there on the right-hand side. Hopefully you will remember what these little boyos are, what causes them. If you don't, check it up. All right, add it to your notes. See you in 10. Right, I've written down a few. You might have got some of these. You're going to need to take a little bit of time to have a look at them. There's quite a lot in here that will come up in your cranial nerve examination. So at this stage, you probably won't notice them as a red flag until you actually go and do the tests. Now, there's some here that you're going to have to look up. So, for example, when we come down to the pupils, so nystagmus, psoas, and Horner syndrome, you're going to need to know about those. You're going to need to visually be able to check them up. So, I want you doing that. I want you to get an image for all these things because it doesn't necessarily come up in this presentation. So when we look at these ones, the motor function, sensation, I was going to say tone and gait, they come up in our cerebellar function tests. The rash, the photophobia and stuff, that comes up in meningitis. But these are basically just things that if you went to a patient and the relative said to you, all of a sudden they're not talking. All right, so you could think moody, or you could think, hold on a minute, there's a bit of neuro going on here, isn't there? And maybe do a little bit more of an investigation. So take note of these. Well, don't take note of them, don't note them down. Look into them all. Make sure you understand what each one of these things mean. Try and figure yourself in a scenario on placement where you might have come across these. Did you check it up? Did you look further into it? Probably not. Some of these might not have even seemed that serious to you at the time, but they are. They're not completely normal. Right. Moving on to history taking. So, the history taking in the neurological system isn't that much different from normal history taking. So, as usual, I prefer you to use the medical model, working at the presenting complaint, the history of presenting complaint, what you find on examination, family history, social history, surgical history, drug history, allergy history, a review of systems, and then a plan. If there's any pain there, I want you to do a Socrates or an OPQRST. I want you to be asking secondary questions. So, for example, somebody takes a certain medication. Instead of just noting it down, I want you to be thinking, what's that for? Look it up. Yeah, all the different type of epileptic and seizure medications, all of the blood thinners, blood pressure, they come under cardiovascular and neuro. All right, so when you are taking the history, there's a couple of things that you need to look out for. So I've noted them down here. The a very few little red flags here, but the most common ones that you come across. So mental status changing. So that would be probably noted on your patient report form as a change in GCS, but sometimes the relative says to you, I don't know. They're just not behaving. They're just not being themselves. I can't put my finger on it. I don't know what's wrong. He's just not acting the way he normally does. For me, that's a massive red flag. All right. Sometimes it can mean that there's a little bit of like angst going on or whatever. But a lot of the time, people will come out of that when you arrive. So any type of behavioral changes are massive red flags. The same in the mental state. You know, if somebody starts to forget things, a lot of people would be going, is this the start of dementia? But it could be something like a lot more acute, so that there's a brain injury, a brain bleed, some type of ischemia happening there and then. Don't ignore it. Any type of behavioral changes. Headache, we do a lot on headaches in this section. So there's some type of headaches that are more worrying than others. So those sudden onsets. You heard of a thunderclap headache? The thunderclap headache is something that you'll need to look up. We'll do a little bit more work on headaches. Headache with something, so a headache with vomiting, headache with pupil changes, headache with bleeding, headache with seizure. Loads of different headaches will come up. Migraines, don't treat them as nothing. Um, People will tell you whether they're presenting with a different type of migraine than they normally would present with. And you've got to take notice of that. If they say normally my migraines only come on a weekend, that's real. It's not just because they're um, they're giving you some random information. That's real. That comes on because maybe they're stressed Monday to Friday. Maybe they work with a computer screen Monday to Friday. Maybe they play video games Monday to Friday. It comes on a Saturday. It comes on with weather changes. Oh, my migraine normally comes on without eat cheese, but today suddenly it's there and it's different and it's worse. Find out about their migraine. It's never just a migraine. Find out where the pain is, what symptoms they've had with it. Same with all kind of headaches. Don't use it as a standalone. Think what else comes with it. Anything at all that comes with it might be relevant. All right, seizures. So I'm thinking about mostly non-epileptic seizures. So with epileptic seizures, you can ask, is this the way that it normally presents? Is it normally the same length of time? The recovery time, has that been prolonged, extended? Was that the same kind of auras leading up to it? Or you might have non-epileptic seizures. So the first seizure, the unexplained seizure, the cocaine seizure, the hypoglycemic seizure. There's lots and lots of different types of seizures. You'll notice one of the tasks on today's system is to listen to the podcast from the resource room guys. That's an hour long, and I know that's a lot of your time, but this could be done like when you're driving somewhere or when you're having a bath, something like that. It's a really good way of studying. Anyway, there's a whole 1 hour podcast about seizures. Syncope, so any type of faint is always a little bit sus. So whether you can put that down to the cardiovascular system, whether you can put it down to hypoglycemia or whatever, try to suss out what makes the fit, why it happened. But if you can't explain it, sorry, the faint, if you can't explain it, think neuro. And lastly, confusion. Again, something that is brand new in onset and something that you probably can't explain. We don't want to be looking at, they've been confused for about 2 years now. For us in the neurological system, that's probably not something that we're going to investigate. However, if they've had hours of confusion, then we're thinking either we're going down the route of some type of infection, or we're thinking, could this be a neurological event? And quite often it is. All right, so there's a couple of other words here that you need to learn in order to take your history and know why they're significant. Most of them are in terms of strokes, CVAs, so like ischemic strokes and bleeding strokes. So they would give you a loss of ability to talk or a loss of ability to find your words. A lot of people with speeches know exactly, with strokes, they know exactly what you're trying to say. They know exactly what they're trying to say. The words just don't come out, or you might have jumbled up odd words. Please don't get it mixed up with alcoholism. If someone's had a drink, they can still be having a stroke. So do all the tests you possibly can. Don't rule anything out until you're absolutely sure. Right, when you're taking your observations, what is significant? What order should you do it in? Now, I'm a big fan of this. You'll probably have noticed that by now. I want you guys to be thinking logically. If you think someone's coming up with a neurological complaint, what are you going to want to look in first? Like for me, it's not really about the respirate and the SATs unless there's something secondary. So the neurological event has caused hypoxia or has caused a low respirate. I'm looking first of all at things like their level of consciousness, their blood pressure and their pupils. They're my 3 most important things when I'm looking at neurological complaints. Then I'm going to go on and do the rest of them. So the AVPU and GCS, that will show if there's some kind of blockage here on understanding commands or saying to your arm move, and then your arm not doing anything. When you pinch someone up here, for example, not that I ever pinched any patients, and their hand would move out, they can't actually localize where the pain is. but they know it's somewhere in their arm. So when you're looking at GCS, especially when it comes to motor responses, really, really look into that, especially in the motor responses levels 5, 4, 3, and 2. Really, really important, overlooked. GCS is actually made up for the neurological system, not really for anything else. But I didn't say that anyway. So I've put in GCS. I'm looking at the blood pressure because I'm thinking about bleeds, and I'm looking particularly at hypertension. We talked before about the difference between the systolic and the diastolic. I'm looking at that narrowing, thinking about intracranial pressure. Pupils, so much we can do on pupils. You can write a dissertation about pupils. So the pupils, are they equal? Are they round? Seen any pupils that aren't round? Different presentations of pupils. For example, like nystagmus, Horner's syndrome. See my eye there? See what I can do? Different pupil presentations, one different size than the other, different shape than the other, one reacting to light, one not reacting to the light. Thinking about head injuries, thinking about hypoxia, thinking about, again, intracranial pressure, thinking about bleeding. Learn what the pupils are going to be doing when a patient is having a stroke. They're not always going to be different. What about where the stroke is? Will that affect the pupils? Then I'm going to move on to blood glucose. The reason I'm moving on to blood glucose next is because it's something I want to rule out quite quickly. Some patients with hypoglycemia will present to you like they're having a stroke, and you will think, quick, fast test, let's get this patient in. And they might possibly fail the fast test. However, who be the fool who didn't check out the blood glucose? So you check out your blood glucose. It's reading under 4, correct that. Then do your fast test afterwards. Again, one of those things, they can happen at once, but quite often you'll make the mistake at least once in your career where you think someone's having a massive stroke and they're having a hypo. Give them a bit of jam and toast, right as rain. Anyway, so pulse. I'm looking at pulse and respirate, thinking about my intracranial pressure here, thinking about the Cushing's triad. So that's why I'm doing pulse and respirate next. Temperature, thinking about infections mostly. Oxygen saturation, that's coming further down the line. Again, that's just going in with my intracranial pressure. End tidal CO2, is that relevant? Is it not? I would do it anyway. If you've got the time, I wouldn't delay going to hospital or treating a patient just to do end tidal CO2. Really, really, really good if you've got a patient who's having a bleed or intracranial pressure or coning. Do you know the word coning? When the brain tries to go down goes down the brainstem, that's coning. You will get different type of agonal breathing, Cheney-Stokes breathing, and you can monitor that, don't forget, by using the end tidal CO2 nasal cannula. So it is a good idea to pop it on, especially for monitoring respirate and respiratory pattern. ECG. The jury's out with the ECG. Personally, I'm thinking there's not much point in doing an ECG if the patient is presenting to you as neurological. However, some people are very risk adverse and they want to do an ECG for like everything. So for me, I wouldn't be doing it in anything that you think is time critical. If you're staying at home and you're doing a little cranial nerve test, etc., you want to give them the works, then do an ECG there. But for me, it doesn't really fit into the neurological system. I'm not going to tell you off if you do it unless you're wasting time, unless they should be at hospital. Right. So here's a little reminder of intracranial pressure. I have a link here. So if you go to the static version, that can tell you a little bit more about the pulse pressure. As you know, some of you spoke with me about that when we did our abdominal system. So learn a little bit more about that. In terms of Cushing's triad, that's raised intracranial pressure. So that's the opposite of shock. This little boyo here shows you that. That shows you that exam. So with shock, you learned about the pulse rate going up and the rest rate going up, but the blood pressure dropping, especially in hypovolemic shock. It's the opposite with intracranial pressure. The blood pressure goes up, although actually here we've written systolic blood pressure goes up, but the pulse rate comes down and the resps come down. That's abnormal. If you ever see that happening on placement, please take notice. Massive red flag, dingling, ring a bell. The rest rate is coming down, the pulse rate's coming down, but the blood pressure's gone up. Man, that's a pressure cooker that's going to explode. All right, so be careful if you ever see that. Um, you will see some other signs and symptoms with raised intracranial pressure, but to be honest with you, that is coming along like quite a lot of our neurological complaints. So you'll see quite a lot of these in any of the neurological assessments that you're doing. So it's more important that you're looking at the patterns of the blood pressure, pulse, and rest rate. Things that can cause intracranial pressure are mostly bleeds, but it can also be, remember we talked about collars? Yeah, collars, cervical collars, those badness. Having some kind of restriction around your neck, like this is why I've worn my polo neck today, to display a restriction around the neck for intracranial pressure that can build the pressure up in your head, and eventually that swelling, that's what causes coning. So essentially what treatment is for this is, well, if you can bring the blood pressure down or the swelling down, that's great. But how do you do that? Medication won't necessarily do that quickly. So you have to have some kind of release for the pressure or for the blood. And that would be in terms of a shunt. What they used to do is a borehole. So literally drill a bit of a hole into the brain to let the pressure come out, let the blood come out. I suppose it's a little bit like your collapsed lung scenario, your pneumothorax. You just need to get rid of that extra pressure so that the brain can react as normal. Intracranial pressure could cause death. All right, so lecture in this sense is look out for it. Blood pressure, rests, heart rate. All right, time for another cup of tea. So, headaches, one of my favorite topics. I love headaches, not having them, but I love trying to figure out what's up with someone. So, loads and loads of red flags and loads of different types of headache. So, I've got a task for you here. I've put 15 minutes on it. Take as long as you need for it. And I want you to make a list of all of the causes of headache. Then, when you're doing that, think about how it will present. Is this a headache that presents as a headache, or is it a headache as a symptom of something else? So that's what I mean here by primary and secondary. So just looking down the bottom here, note out of these which is a primary headache and which is a secondary headache. Try and note differently on the side which ones you're most worried about. What kind of headaches would make you think, hold on, this is really serious? So for me, it would be a headache with intracranial pressure, something like that, or a headache with a loss of movement, a loss of motor response. Anyway, I want you to put this on Menti. I've left Menti open for 2 weeks from today, so that is the 16th. And I've written on Menti primary headaches and secondary headaches. I want us to make a massive word cloud on it. The more obscure, the better, but you can write 10 answers on each one of those. All right, so pause me and get on with that, and I'll see you in a minute. All right, here is a lovely little infograph. The one on the left here are the causes of headaches. Now, of course, this is not consuming everything. This is not telling you all about headaches here. It's just an infograph to tell you a few of the main ones. Here, the SNOOP mnemonic, that is for real life-threatening headaches. So these are your massive red flags. So have a look at that. See if you can bring up Snoop into your. Sorry, all that's going in my head is somebody say just eat me. Big delivery. Anyway, I've written down there what those P's mean at the bottom. So take time to understand this. I totally embarrassed myself. I'm such a dick. Right, moving on to meningitis. Hopefully, most of you guys know about meningitis. It can be fatal. It can be super, super serious. Most of you have got the vaccine. but the vaccine doesn't cover all types of meningitis. So your two main types that you've got are viral and bacterial. Viral is the most common one. Bacterial, however, is the most fatal one. So what you will need to do is look at the signs and symptoms, which this man here shows you. I had meningitis. I'm sure I've probably told you before. I had viral meningitis and spent 2 weeks in hospital. Now, how that presented to me was I was in work doing a night shift and my glands went up. That's it. I was like, why are my glands up? Then I started vomiting. Then I went, feel a bit weird. So brought the patient into hospital that we were with and then got checked over, got admitted. You don't always have all of the signs there. I didn't start with a stiff neck. Literally just hyperlymphedemia and vomiting. So the most common symptoms that you will see are probably the ones you already know about. So it's the photophobia, don't like bright light, stinging headache, especially when you see the light. Even when the light's blocked out, you got your sunglasses on and everything, terrible headache. That headache, because it's the meninges that are actually inflamed, will go the whole way down your neck. This is why people have the stiff neck. So you'll see paramedics on the road and medics saying, "Oh, can you touch your chin with your chest?" Somebody's got meningitis and they've got the stiff neck, they'll go that far. They won't even want to do it. They won't go, "Oh yeah, I've got a load of pain." No, they're just not going to do it. Rash. So people think meningitis, they think rash. The rash hardly ever appears, and sometimes when it does appear, it's a late sign. So understand what the rash looks like. Understand how to do the glass test, the tumbler test, to find out whether the rash is blanching or non-blanching. But don't always rely on the rash confirming to you that it's meningitis. Now, I want you to look up your gyro calc on this because this is quite a significant point here. When we are doing meningitis testing and we think we have a confirmed case, we can give benzopenicillin. However, check your gyro calc because quite often we're fighting about can we give it if there is not the presence of a rash. So I'm pretty sure at the moment you can't give it unless there's a rash there. And the rash is such a late stage. Anyway, get this person into hospital if you're expecting them of meningitis. Learn all the signs and symptoms of meningitis. In the lesson plan on Moodle, you will notice Koenig's and Brudzinski's signs. They are signs to test for meningitis. They are not 100% foolproof, but they are signs in which you can aggravate the meninges and you will get a reaction doing those tests if somebody has meningitis, if the tests, if they work. Like I'm saying, they don't always work. But I need you to know how to do Koenig's and Brudzinski's sign, as well as the tumbler sign. So on this, we have a short video here on meningitis. Please watch that from the static version. But for now, I'm going to move on. This slide is to show you about how meningitis shows up on brown and black skin. As you can see here, we've got a new resource, which is called Mind the Gap. So I've been sure to reference properly Malone. Malone is a student at St. George's who made this resource because there just wasn't any features for rashes and lots of different skin conditions that weren't on white people. And you will notice that whenever you look in books, all of the rashes seem to be on white skin. But guess what? It doesn't just happen to white people. So anyway, here are some images of meningitis rash on brown and black skin. Moving on to stroke. Now, you guys already know a lot about stroke. You've done this in Pat Path's class. I haven't gone over it again because this is something you should know off by heart. Fast test. You should know the signs and symptoms of stroke. You should know the risk factors. You should know the people who are likely to get it. You should know the red flags. You should know how long you've got to get this patient into hospital, which hospitals you're going to, and the ash, ice, or blue call that you're going to make. So this is a nice little guide here by the National Stroke Association, and it's showing you the risk factors. So if you have a patient who ticks lots of these boxes, they might be in line for a stroke. So it's good when you're taking history to be asking about these kind of things. Make sure that you know about AF. Um, how do you see AF on in ECG? I'm getting distracted. I'm thinking about a story about the patient that took the ECG out and went, "Wow, tachycardia! Look at the rate of that. The patient's heart is really fast. I think it's fast AF." And the man goes, "God, yeah, you're right. You don't mince your words, do you? Thinking the AF meant something else. That's fast as, you know." So anyway, fast AF or any type of AF will present with no P waves and an irregular rhythm. So this is when it might be worthwhile doing an ECG, especially if a patient's not having a stroke. But if they've got AF, they're going to be at more risk. So know your types of stroke. So you've got your ischemic stroke, whereby your arteries are thinning and there's a blockage there, and you've got your bleeding stroke, hemorrhagic stroke. You know as well that the mini stroke, the TIA, is a precursor to stroke. So symptoms normally clear up within 24 hours. However, patients that have TIAs are eventually going to have a bigger stroke because that blockage is only temporary, but you can imagine that means that there's probably a massive, big atheroma that it's trying to get past. Remember our carotid bruits? When we were listening in the cardiovascular system to the carotid artery for a bruit, that can be what causes a stroke. So looking out for that. You can read up a little bit more about strokes. There is stuff on the Moodle page, but also I've put a little 3-minute video in here as well, just to give you a bit of a recap. So if you're feeling not too confident on it, please have a look at that. Right, moving on to the mini mental test. We have two here. So the first mini mental test is what we as paramedics tend to do. We give patient series of questions that are appropriate to them. So when I say are appropriate to them, I don't want, that you asking patients something like, "Oh yeah, who is the latest person to get kicked out of I'm a Celebrity, Get Me Out of Here?" Something like that, or "Oh, what's your favorite skin in Fortnite?" No, they want things that they will be able to answer. So make sure you know the answer as well. So, for example, these are the general kind of questions that we would expect to ask, but you might not know when World War II started. You might not know who's the Prime Minister. So you can't test them if you don't know the answers to the question. And it's not fair if they don't know the answers to the question. So 10 questions that seem pretty straightforward. See what they're orientated to. The first thing should be an address. So they always say in the books 42 West Street, something like that. You get done all of the questions, and then the last question you say, "What is that address I asked you to remember?" You need to get more than 8 out of 10 to pass the test. Okay. So if a patient is getting like 5 or 6, they've failed a mini mental test. So there's something going on there with their short-term or their long-term memory. From these questions, you can gauge whether it is short-term or long-term. There is another more complicated test. This is used in hospitals and GP surgery, but you can use it if you want. I've put a link there for you to download this if you want to. And this is basically separating the mini mental test into different areas. So orientation, registration, attention and calculation, recall and language. Then at the bottom is copying. So it's quite complex. You need a little bit of time to do this. So we don't tend to do it out on the road, but by all means, if you want to test it, please do. If you want to do it on your relatives or whatever, you can do that too. It's normally used for diagnosing things like Alzheimer's and dementia. Next, from the mini mental exam, we are going to move on to cranial nerve assessment. Now, I have put some other resources there for the cranial nerve assessment. I hate where I live sometimes, so noisy. Um, what I tend to ask you to do is to do it in a certain order. So, as you can see here, I've grouped some of them together. So, for example, here we go. I've grouped these three together. You can do the same tests on all of these. Oh, gosh. Um, all right. I, as you can, sorry, I'm losing my track again. I have put cranial nerve PowerPoint separate up there so that you can see how to do each test. This is kind of like a screenshot of what you're doing. Um, we can do some tests on the road, but some of them we don't do. It's just not convenient or just not necessary. However, it's good for you to know them and it's good for you to do some type of tests because you will see patients that present with acranial nerve damage. Right, so learn these. Like I said, I've put loads of resources in about cranial nerves. Let me know if you've got any questions about them. And the last test that we do is the cerebellar function test. So this involves testing a patient's gait. That's basically their walking, standing, that kind of thing. To perform a Romberg test, which is a standing test, check for tremors, test their tone, and test their coordination. Um, this is Romberg's test. Basically, you're going to be testing their ability to stand up, to close their eyes and stay standing, see if they're swaying, that kind of thing. Then they have to put their arms out in front of them. Again, keep the eyes closed, see if they're swaying all over the place. And then whilst they're there, notice typo, get them to make a fist, stick out the fingers in both hands, get them to touch nose, all while just standing. That's Romberg's test. So going back to your whole cerebellar function test, first one with the gait, get them to stand up, just nice and still, see how they're standing. Get them to walk, and if they usually use a walker, let them use the walker. See how their heel touches the floor, see how their toes lift off. Watch what their arms are doing. See what they're like whenever they turn around to come back to you. You're looking for where they kind of lose their momentum, where they're most unsteady. Then get them to walk heel to toe. So that's not taking normal steps. That's literally putting your foot down and then your other foot touching heel to toe in that way. After you do Romberg's test, checking for a tremor. So literally just asking the patient to put their hands outstretched. You can then afterwards get them to do it with their eyes closed. If you're not sure, stick a sheet of paper over it and you'll soon notice whether there's a tremor or not. This is different from the beta 2 agonist tremor, and this is different from liver flap. This is just a generic tremor. Neurological problem. You're going to check their tone. So this is the same kind of thing as you do in the fast test, checking their strength, checking it on their arms, on their shoulders, like shrug shoulders, and checking it on their elbows, checking it on their wrists. All right, you put your resistance to them and see how strong they are. Checking both sides, bilateral, is it the same? And then their coordination. First of all, you're going to get the patient to clap. You're going to get them to turn their hands over and clap that way. See if they can do that. You're going to get the patient to put their arms out, touch their nose. Do it again, other hand. Do it again with their eyes shut, etc. And then again, get the patient to lie down on the bed, get them with their right leg to run their heel over their left shin. Same on the other side. This checks their coordination. As you know, with cerebellum, it's all to do about balance, movement, and coordination. So it might be that they're having some type of event, like I've written down here. It can be a stroke, it can be a lesion, tumor, that kind of thing, MS. And they will probably pass all their other tests. They'll probably pass the fast test. They'll pass the cranial nerve test. Their OBS might be normal. However, their cerebellar function test might not be normal. That's a very, very quick roundup of the neurological system. Please, please do the other work. Do your homework. I need to give you more work to do about pupils and do this seizure podcast. Any questions, just let me know. All right. I shall see you soon.